Hey, hello, I'm Dr. Bill Bird. This is Sherry DeWalt. Hey, Sherry.
Hi.
So we're here at Facebook Live for CGH on another Thursday, a bow tie Thursday. So hey, Sherry's going to kind of kick this off. She's with the foundation, the CGH Foundation, and actually today's talk was going to be part of the Growing Healthy series that we normally have down in our auditorium. But you know, something else is going on right now that makes that not quite as easy to happen. So, Sherry, I'm going to let you talk a few minutes.
Okay. So the CGH Health Foundation has been doing these Growing Healthier programs for a long time, many years, usually a live presentation. And so once a month, Dr. Bird lets us hijack his program and offer our regularly scheduled. So this month, our presenter is Concha Sitter, who is a nurse practitioner in our gastroenterology department.
Yay, Concha!
Yeah, the title of her program was A Gut Feeling. And she's going to be talking to Dr. Bird about gastrointestinal disorder, fatty liver disease, and colorectal exams, and all of those things. So all of our programs are recorded, and if you would like to watch any of the past Growing Healthier programs, you can find them on the CGH website, on our YouTube channel there. And I'm going to go ahead and turn it over to Dr. Bird and let Concha slide in here.
Thanks, Sherry. This is going to be our best Growing Healthy program ever. No pressure, Concha.
Yeah, right.
Hey there.
How are you doing?
I'm good. So this is Concha Sitter, everybody. Concha is one of our nurse practitioners in the GI department. She is outstanding. So glad to have her here today. And yeah, so I'm going to kick it off and start asking questions rapid fire because I probably have more questions than we have time. And there's GI is there's so many things going on in GI. And by all means, if you have questions as we're talking, shoot them our way and we'll ask those of Concha. And like we did last time, we'll do the thing with Concha, go through some questions for 20-30 minutes, and then when we're done with that, I'll pop on just any COVID questions that come up from all of you, and I'll just kind of give a COVID up to date in terms of the area here. So let's kick it off, Concha. So nurse practitioners. So when you get done with school, you can go a lot of different paths.
Exactly.
Yes. So how did you end up in GI, and how long have you been doing that thing there in GI?
Well, interestingly enough, when I started here at CGH Medical Center, or back then it was Sterling Rock Falls Clinic, I was working with Dr. Joseph Gaziano. That's who hired me back in 1988. So I've been here 32 years.
Wow.
So
you were like a teenager when you started, weren't you?
I was 4 years old. So when I started, obviously, I got to know GI, got to know the practice, got to know Dr. Gaziano. So then when I left temporarily, to go back to school, finished, it was a right fit at the time because I knew Dr. Gaziano, I knew his practice, I knew the patients, they knew me. So it worked out well. It was just kind of, the way it was meant to be.
So in 88?
1988.
Gosh, I didn't realize that long. Okay.
Been here 32 years.
All right. Wow.
Mm-hmm. So out of that time, the last a little over 19 have been as a nurse practitioner in gastroenterology.
Okay, so GI nurse practitioner. Okay, that's what I was thinking. I'm
Correct.
thinking. Okay, because when I came here, you were actually doing you were like the nurse in charge of the clinic or something like that, weren't
Well,
you?
yes, when I was going to school, I became the DON.
Yeah.
They made me the DON
Yeah.
when I was going to school. Mm-hmm.
Yeah. Okay, I thought so. So. Okay, good.
But like I said, so it actually worked out well because then I got to know the foundation,
Mm-hmm.
the clinic, how it worked and put it all together, and coming back I understand all that.
Sure.
It works out well.
Yeah, good.
Mm-hmm.
So I'm going to kind of kick into some of these different things that happen in the GI world that I want to pick your brain about, all right?
Okay, sounds good.
First one is one that I know has changed quite a bit in your career.
Mm-hmm.
Hepatitis C. So, back in the day, not good. You have Hep C, and you throw a little interferon at it and that kind of stuff, but it wasn't like, if you had that, your chances for bad things, cirrhosis, liver cancer, all that kind of stuff, needing a transplant.
Correct.
What's changed And how's it changed?
Oh, it's changed immensely. When I first started, and as you mentioned, interferon was the medication that was used. And that's a protein commonly in our body. So patients took interferon injections. They had to take the injections 3 times per week, but they were miserable. I mean, they would have fever from injecting a foreign substance into their body. They were fatigued, and the cure rates were pretty low.
Yeah. Despite all that pain and suffering, the cure rate wasn't that great.
Correct. I mean,
Yeah.
patients, they were lucky if it was like 16 to 20% cure rate.
Yeah.
Then it slowly started to evolve where we came out with what's called pegylated interferon. So that was interferon, but they put a molecule in there to make the effects last longer. So patients gave themselves an injection once a week. Got a little better. Eventually we started getting into the oral medications, but they got better and better, and we are where we are now. The medications are fantastic. There's several different medications, but they work now primarily on directing the treatment towards killing the virus that's in the liver.
Okay.
So, and the treatment course is definitely shortened, because before, when patients took like medication therapy, it could be for 6 months, it could be for a year, because it was dependent on what's called genotype. So I always tell patients, just imagine like if you're going to buy a car. There's different types of car. It's still a car whether you buy a Ford, a Buick, Cadillac, they're all cars. So with hepatitis C, there's actually 6 genotypes. Previously, depending on the genotype, was the medication that got used. But now, some of the medications are what's called pan-genotypic. That means they work on all the genotypes.
Oh.
And the duration of therapy is just shortened. One of the medications that's pan-genotypic is for 8 weeks. There's another one that the therapy is generally only for 12 weeks. So
Yeah.
the duration course
That's nice.
has immensely improved, and the success rates have improved immensely. I mean, we're talking overall average success rates is about like 96 to 98%. Certainly it varies if someone has cirrhosis of the liver.
Yeah,
The
yeah.
rates are a little lower, but I
Yeah.
mean, quick, short, and
Yeah.
one of the medications is just 1 pill once a day. One of the other ones is just 3 pills. But again, it's only once a day. So
That's awesome.
it's awesome. That's greatly improved.
Yeah, yeah. So, which makes it even more important to know if you've got hepatitis C, right? Because if you have it, used to be like, okay, so, but now, if you have it, boy, you can fix it and prevent some pretty bad stuff. So, there are recommendations about who should be screened for Hep C, Concha. What's the latest on
Sure.
that?
The latest actually came out in 2020. The CDC now recommends anyone over the age of 18 be tested for hepatitis C. Previously, it was just baby boomers because they had the highest risk. Now they're saying anyone over the age of 18 be tested at least once.
Yeah.
And it's very simple. It's just a blood test. It's an HCV antibody test. Now, if it's negative, great. Now, if it comes back positive, still doesn't mean necessarily you have chronic disease. That some individuals can be positive, they got exposed to the virus, but then their body is able to get rid of it on its own. So if the first test comes back positive, there's a second test that we do that's called HCV RNA to detect if a person has chronic disease or not.
Yep, good. And I saw a patient today in the hospital who had, been treated for it, and he said, hey, they've told me I'm cured. And I said, I bet you are. Yeah, what the patient did have, though, was a little bit of cirrhosis, too. So what's the deal on that? If you have cirrhosis before you get treated, can it reverse? Can you get rid of some of that cirrhosis?
Well, not necessarily reverse itself, but it can be improved upon.
Okay.
Because what happens is there's other things that can give a person cirrhosis, not just hepatitis C. For example, which we're going to talk about in a little bit here. They could have a touch of
All our questions are
fatty liver.
spontaneous, Concha.
Sure.
There wouldn't be any questions you already know in advance.
But it might be, like fatty liver. Fatty liver over time can progress and into cirrhosis of liver, unfortunately. Or if someone has a high consumption of alcohol, that could lead to cirrhosis of the liver. Oh, there's other liver diseases also that can lead to cirrhosis.
Yep.
So there might have been other underlying factors that contributed to that.
Yeah, good. So 18 and up, get screened.
Correct. 18 and up get screened.
Okay. I want to transition to another one you know pretty well, and that's colorectal cancer screening.
Mm-hmm.
So what's the latest on this in terms of recommendations, Concha?
So the recommendations have been, for a long time, individuals starting at the age of 50 to get screened. But we do know that certain ethnic groups African Americans have a higher risk of getting colorectal cancer, so the recommendations have been that they start screening at the age of 45.
Okay.
Now, other factors play into that. Let's say if someone has a family history of colon cancer or colon polyps, those individuals start screening sooner. So, depends on the age of the first degree relative that got diagnosed. So, for example, let's say your mother had colon polyps that were precancerous at age 62. Then that individual starts screening at age 40, because generally what we do is we subtract 10 years from the age of the individual that was affected in their family from that age, or the age of 40, whichever comes first. So usually age 40 comes first. For some though, it could be before even age 40.
Yeah, so if you're one of your parents colon cancer in their 40s, you just subtract 10 from that, so you'd be
Correct.
starting your colonoscopy sometime in your 30s.
Correct.
Okay.
And then for yourself as the individual, let's say if you end up having colon polyps that are precancerous, you're going to have periodic examinations also the remainder of your life, and it'll be dependent on what they find on your particular colonoscopy.
Yeah. So I wanted to ask you too, Concha, because colonoscopies, I've had them. A lot of people have had them. It's a kind of you use up a lot of your plumbing that night before. It gets a lot of use, and then beyond that, you just get your happy juice and you do your test and off you go. Some folks just don't want to do that. So can you kind of speak to any other options that might be out there?
Sure. So probably the biggest one individuals have seen on the TV is the commercial for what's called Cologuard. Basically, people call it a colonoscopy in a box, which is not entirely correct. But what Cologuard does is we normally shed cells all the time, including in our colon. So Cologuard detects for cells that are altered based on their DNA, and then it gets analyzed in the stool specimen. So someone has a box sent to their home, they have a stool, put it in the box, it gets sent away, and then they analyze it. So it can pick up overall about 92% of cancers. Now, as it progresses, let's say hypothetically if someone has an advanced cancer, it's less likely to pick it up, but about 92% of the time it can pick it up. Now, it does have also what's called false negative and false positives. So individuals might get a false positive where it looks like there's something in the colon. So if it's present, a person does now require colonoscopy, because we actually have to go in there and look to see, okay, why was it false? Or, why was it positive? We don't know if it's false positive or true positive. So a person might have it done, and then it truly ends up being negative, that nothing's found in their colon. On the flip side though, it could come back that it's negative. About 13% of individuals will have a negative result, when in reality they may have had like colon polyps or colon cancer at the time that aren't detected.
How often do you have to do that one?
Well, Cologuard, based on their standards, it's every 3 years. Now, the American Cancer Society says if you have Cologuard, you really should follow it up with a colonoscopy, 3 years later, so at least you're getting a standard colonoscopy to make sure nothing's truly been missed.
Okay.
There's also what's called fecal occult immunoassay test. So those are tests where someone has the stools, and then they take, it almost looks like a little Q-tip, they swipe it on the stool, they bring it back to the lab, and it gets analyzed again. They're looking for a human hemoglobin in there. So again,
like
if it
blood,
ends up,
basically,
or
right?
blood, exactly.
Yeah.
So if it comes back negative, then they know, okay, I'm good for now. The recommendations are you do that every year. But it's also recommended, if you're doing that, you should at least have what's called a barium enema. So what a barium enema does is then actually evaluate the colon
I'd rather have a
itself.
colonoscopy, I think.
I agree with you. What the barium enema does is evaluate the colon, but with X-ray imaging. So you still have, because people think, okay, I'm not going to have to do a bowel prep. You still have to get all cleaned out because they want to make sure they don't miss anything. Then you come to the hospital, they do an X-ray where they actually insert barium into the colon, take pictures, at different angles, and look for anything abnormal in there. So that's a possibility. Now they also do what's called a virtual colonoscopy. Now we don't have that at our institution, but larger institutions have a virtual colonoscopy. So again, for virtual colonoscopy, individuals do have to prep because they want to take a good look at the colon, but it's basically like doing a CAT scan or a CT. they put it together like a movie, looking for any abnormalities as it's going through there. And again, they might detect potentially a polyp, then a person's gonna have to have a repeat prep, undergo a colonoscopy to really
Yeah.
look, are there any polyps, and remove the polyps there.
Okay.
Years ago, we used to do what's called flexible sigmoidoscopy.
I did those in my office, yeah.
Exactly, where
Yeah.
we looked at the left side of the colon, but primarily now in the US, standard of care is doing a colonoscopy or one of these other tests along with it.
Yeah, good. Yeah, so I guess you kind of get that, there's a range of options. Ideally, you have a colonoscopy done. And do it every 10 years if everything's normal in terms of that, so good. Okay, I'm going to throw an acronym out. NASH, N-A-S-H. NASH, for those of you listening. Katja, tell us a little bit about NASH.
Okay, so what NASH is, it stands for non-alcoholic steatohepatitis. So that means it has nothing to do with alcohol.
What's the lay term for that? What would you call that?
In terms of fatty liver?
Yeah, you
So
call
it's like fatty liver that's
Yeah.
progressed though.
Yeah.
So what happens is, we're all born with fat. That's just a reality. We're all born with fat. We have fat in our fat cells. Once we exceed the fat in our fat cells, it spills over into our muscles and then into our organs, in this case, the liver. So fat should be under 5%. Anything beyond 5% is called fatty liver. But, someone might have an x-ray done and it shows infiltration of fat or hepatic steatosis. But we really don't know how much fat is in there. Short of if a person had liver biopsy, but no one wants to do a liver biopsy, you don't really need one unless it's
Yeah.
indicated. But what happens is, over time, that fat causes inflammation, causes hepatocellular injury, and then a person develops scar tissue of the liver. So that's called NASH. Over time, actually, fat causing the inflammation, causing more scar tissue can progress. When we were talking about earlier cirrhosis, a person actually can get cirrhosis of the liver that purely started off by fat.
Yeah.
So, those are the things we want to try to identify, because a lot of us probably have fatty liver and we don't even know that. Generally, it doesn't give us any symptoms.
Yeah.
Some individuals might go and get a blood test, and the blood test shows, liver enzymes might be slightly elevated.
Yeah.
That might be an indication, but a lot
That's a
of
pretty
people
crude
have.
test to try to find that
It
out.
is, it is.
Yeah.
Because about 30% of individuals in the U.S. have, fatty liver by itself. Probably about 60 to 80% of individuals that are obese have fatty liver, but we also see it's very common in diabetics too.
Yeah. I was at a conference this winter before all this hit. I was at a conference. I was away from here. Anyhow, and they were talking about that, and if I remember right, they said that it used to be that hepatitis C was what caused most people to get liver transplants.
Correct.
Now, and NASH was like third on the list, and alcohol was in there too. And now it's flipped.
Correct.
And now a lot more people need liver transplants because of, believe it or not, NASH
Correct.
than because of the Hep C.
That is true.
Yeah.
And so, we can't. Who would have imagined that because fatty liver progressed, that people need transplants,
Yeah.
because of the cirrhosis. So if we can try to identify it early, treat it. And unfortunately, right now there's no medication to treat it.
Yeah.
It's in the pipeline. Definitely, it's in the pipeline. But there's no medication as of today, like I said, to treat it. So it's basically what we can do to help ourselves,
Right.
and that includes like a low-fat diet, exercise,
Sure.
trying to lose weight and trying to identify the
I need
condition
turn
to
mine on
begin
Friday,
with.
sorry. Hey, and they were talking. What's that fancy French food? Is it foie de gras? Is that what it is? Is that what's
Foie gras.
foie gras? and what? And Sherry's here, and that is like liver,
It's
duck
goose
livers.
liver, but
Geese
what
livers.
they do is they tend the geese up and overfeed them until they get so fat, and then
Yeah,
they harvest
so they
them.
overfeed them with just terrible diet, and they just sit still. Well, at this other thing at this conference, they showed a picture of a normal goose liver, and then this, whatever Sherry said the name of it, liver, like 10 times bigger than the normal liver. And the conference speaker's point was, that happens to us too. So, if, and we'll get into just a second here, but if your diet is a pretty bad diet, like 30% NASH or 30% folks that have fatty liver issues, it kind of goes not quite 1-to-1, but pretty close 1-to-1 with number of folks in our country who have weight issues. So you can kind of, I wouldn't say assume, but it's pretty likely if you have a weight issue that your liver has an issue as well. It may not end up being NASH, obviously,
Right,
but I
right.
mean, yeah, do you want to speak to that a little bit about what, health-wise we can do to try to prevent NASH?
Oh, sure. So like I said, as I mentioned, a person wants to maintain, good control of their weight, good control of blood sugar, even tying in there, like if a person has dyslipidemia, meaning like cholesterol issues, getting good control of that. Because as I mentioned, unfortunately, most people don't realize that they have that until they might have some issues. So we can try to identify it. If a person that just undergoes, a lot of times is incidentally they undergo an ultrasound because maybe they think they're having a gallbladder issue, or for whatever reason they're having a CAT scan, maybe they're having abdominal pain and it shows up on a CAT scan. So if we can then identify it, after that point is, okay, it shows fat. Now there is a special scan that we are very fortunate, we have this technology now at CGH, it's called FibroScan. So the ultrasound can just tell us there's fat present, but it cannot tell us how much fat is present. FibroScan uses technology that can actually tell us how much fat is present on the liver. In addition to, if there's scar tissue, it actually can grade it and tell us how much scar tissue is present there. So that'll give us an idea so we can help with individuals, work on it. But we also use FibroScan also when we were talking about hepatitis C.
Yeah.
Because we can also do a FibroScan on someone pre-treatment, see where they're at a year later, post-treatment, see where they're at, or for other liver diseases that we use that too.
That's a nice piece of technology to have, because back in the day you had to stick a needle in somebody to really kind of get a better idea of that.
Exactly, because in order for someone, as Dr. Bird mentioned, a liver biopsy, we had to stick a needle in their liver, get a couple pieces of tissue to look at it. And when they're doing that, imagine just a needle going in your liver. It's just getting a snippet of tissue.
Yeah.
And so it's actually only looking at like 0.002% of your liver, where FibroScan can get like 100 times bigger area of the liver that it's looking at when we're doing the imaging. So it takes, essentially they look like pictures, and then they get analyzed, like I said, and then depending on the disease state, we can say how much fat is there and how much scar tissue is there, if any.
Yeah, that's my vote. I don't want a needle on my side. I'd rather have a little something probe run over my side to take a look at that. So that's a good deal to be able to do that. So yeah, unfortunately, if you're in that category, somebody, make sure that you're aware that we have that here in Sterling. Hey, just this one is a comment from our listener. My niece has nothing but great things to say about Concha. 3 exclamation points. All right, Concha. CGH is the best, hands down. Great doctors and nurses. Well, thank you. Appreciate that. And then great information. Thanks, CGH. Yeah, I told you this was going to be our best Growing Healthy series talk ever. So yeah, trust me on this. When we're still going. So okay, so Concha, we talked about this scan, and yeah, I'm gonna skip down to one that I think is kind of interesting, and that's the microbiome. All right, so micro, M-I-C-R-O, biome, B-I-O-M-E, is kind of I would say it's within the last 10 years, kind of the latest and greatest in GI. Tell us a little bit about that, and what it is, and what do you do if you don't have a really good microbiome, and what does it mean in terms of health and disease? Right.
So there's a lot of information out there about microbiomes, because we all have all these pathogens in our body, including like bacteria.
How many bacteria do we have in our gut? What's the number?
Oh,
something crazy.
It's some crazy number, but I know in terms of like the microbiomes, we have something like 1 trillion.
Oh, it's nuts.
It's a lot.
Yeah.
And so there's a lot of issues that they thought is like if the balance is off. For some, Sherry and I were talking about it a little bit before, as the controversy. Is there a thing called leaky gut, where like in our intestines, we have cells in there. And is there increased permeability, and does that lead to chronic inflammation? Some will say it doesn't really exist. Some will say it does exist. It's controversial. Some obviously the things that we know is we all need to have a healthy diet, because basically, as we were talking about with fatty liver, or what we eat is a lot of what our body is made out of.
Right.
So we want to get a good balance of all the nutrients
Yep.
and the bacteria in our system. Now, I'm going to skip around a little bit, but make
Skip
it
all you
fun.
want, Katja.
Sure. I love to skip.
You go for it.
Because there's probiotics. So
Which is one of the next questions that came your way.
I
Let's
know
talk
it.
about probiotics.
Because probiotics, the thought was, okay, probiotics will help. Get everything in a good balance between the good and the bad. So it's interestingly enough, because you see there's all kinds of probiotics on the market, but the American Gastroenterology Association just came out in June. It just got released in press that they're really questioning, should probiotics be taken on a regular basis? So they were looking at, does the evidence support that a person take them? They're looking at right now that yes, in terms of if someone's on antibiotics to help prevent what's called C. difficile. C. difficile is a colon infection that individuals can get.
So basically, C. diff is your microbiome gets overtaken by another bacteria, which is C. diff, which is not a happy bacteria.
Correct.
It's happy, but
right,
you're not happy.
You're not happy as
you're not happy when it's in you. Right.
So they were looking at, that was one of the recommendations, that take probiotics if you have C. diff. Or if a person has what's called pouchitis, they've had inflammatory bowel disease, they have surgical changes to their anatomy, and if they get inflammation of their pouch, that was another one. Or if a preterm infant has like necrotizing enterocolitis, that was another one. The other ones, they said the evidence was kind of like not necessarily supportive of should someone take it on a regular basis. So I think right now that's up in the air. I don't have a definitive answer, like I said, because that just literally got released like probably 6 weeks ago.
Yeah.
That they're still evaluating the recommendations is should someone take it on a regular basis or not.
Yeah.
Now, other things that we hear about is like eating yogurt. I mean, yogurt is helpful, or kefir, which is a drink. Or like sour cream, other things that kind of help within our own diet to help promote having, that good balance.
Now, I would tell you on yogurt, I was at the last conference I was at about this, was saying that to get enough yogurt to get the probiotic that you need, you'll have fatty liver, because you need to have about 20 servings of yogurt every day to do that. But give it a go if you're more concerned about your microbiome than you are about your fatty liver. All right, so let's talk a little bit too about just kind of this input-output thing. In terms of what we eat and how that affects. Is there any research about that in terms of our microbiome or how our gut health is? If we eat healthy versus unhealthy, will that affect that at all?
Well, the thoughts are obviously if we eat healthier that it should improve that, because if you're having like a diet that's high in fat, a lot of sugars, especially like artificial sweeteners, that can also alter our gut flora. So, overall, yes, it would be beneficial to eat healthy.
Yeah, good. This is my conference day. So I was at another conference at the Mayo Clinic a few years ago, and I still remember this. This guy was talking about people, they actually test and see what the composition of patients' microbiomes are. And he basically could say, based upon a patient's microbiome, how they were going to respond to chemotherapy for, I forget what the cancer was. For some reason in my mind it was a lymphoma of some type. But it was really fascinating that, how we respond even to some medical medicines.
Treatments.
Yeah, it has how healthy your gut is has some bearing on that. So it's fascinating. I think as Concha's career progresses, and she's got a lot of years on those tires, I'm telling you. So
I know. But they're little tires, I hope.
So as her career progresses, and if we're here 10 years talking about this stuff, instead of Hep C, we might be talking about gut bacteria and what the latest and greatest is, and what we've learned, and how people can have a lot better GI health based upon that. Yeah, so good. All right, what was the next one I had? Oh yeah, I did the probiotics thing, and one that's really common, GERD, reflux disease. What's the latest on that, Katja?
Well, not a whole lot has changed in terms of GERD, but we know it's very common. We all have heartburn. I mean, we eat, we get a little bit of heartburn. That's common. But once really, you need to identify: are you having to use like Tums every day? Are you buying the over-the-counter medications and taking them on a regular basis? Then you really should say, gee, I need to have it evaluated. Am I having more than what is beyond considered normal? Because long term, if acid or gastroesophageal reflux is not well controlled, what happens is at the bottom of our food pipe or esophagus, there's a muscle there called the lower esophageal sphincter. So what happens is that muscle can potentially relax, or we might eat foods that cause it to relax when it's not supposed to, or have a higher consumption. For example, if someone smokes, the nicotine will lower the pressure of that muscle.
Yeah.
A diet that's high in fat will do that. Coffee, caffeine, soda, a diet with a lot of citrus products, tomato-based products, all can do that potentially.
Yeah.
So we want to kind of, monitor it with our diet. But once you get, it's constantly, you really should have it evaluated, because over time, potentially individuals can develop a disease called Barrett's esophagus. So what happens is Barrett's esophagus, the acid backs up, irritates the food pipe, and it tries to protect itself. It changes into this precancerous condition called Barrett's. So someone that has Barrett's esophagus has a slightly higher risk of developing esophageal cancer over the normal population. So unfortunately, Barrett's does not show up on a blood test, won't show up on an x-ray. We really need to look for it.
Yeah, right
So
now
that's
they don't
why-
have any dog sniffing tests or anything
Correct.
like that.
I mean, interestingly enough,
Yeah.
it sounds kind of odd. They were looking a few years ago into where they actually had a sponge on a string, and then the sponge going down, and then they would pick up cells and evaluate that, but that really hasn't come to fruition.
Yeah,
at this point.
I wouldn't sign up for that.
No.
I'm not a big sponge string guy.
It goes down,
No,
let's come
no.
up.
That's right.
My sponges are going down and they're staying down, Katja.
Right,
Yeah,
so really, like I
gosh.
said, then we decide, okay, really after 5 years, having a smoke
Mm.
done, and you're really evaluating that.
Okay, good,
Mhm.
good.
And then obviously doing what we can to help ourselves. So if someone smokes, really the smoking
Yeah.
is a whole other issue. But
It
like I
is.
said,
It
stopping
is.
smoking, decreasing it, but trying to control our weight, control our diet.
Yeah.
What we can do to help, with the GERD.
Yeah, yeah. Yeah, for those of you who take what are called proton pump things like Prilosec, help me out here.
Prilosec, Nexium,
Protonics, pantoprazole,
Acifex.
Dexalant, the list goes on. Anyhow, if
correct.
you're on one of those medicines, it's good, but I would just encourage you that maybe once a year or two, make sure your doctor checks your kidney function, because 20
Exactly.
per 100,000 people that are on that can have some kidney issues. And if you happen to have unexplained anemia, just keep that in mind, because even us in the medical field, sometimes we lose track of that people are on those things, and it sometimes can cause some absorption issues, which then can lead to anemia. So just kind of keep that in mind if you're on one of those
Right,
medicines.
because it also can cause a B12 deficiency, a magnesium deficiency, and the other thing is chronic proton pump inhibitor use. Individuals have an increased risk of getting C. difficile, which is a colon infection.
Yeah.
Because on purpose, there's not as much acid because it's being blocked by the proton pump inhibitors.
Yeah, so they're good medicines. Keep taking it if it's working for you. But I'm just saying that that's definitely something to keep in mind.
Exactly, and especially like I said, because as Dr. Bird mentioned, there's so many options available over the counter. So you might not even think when you go to see your doctor to say, I'm taking Nexium or Prilosec over the counter. Maybe you've been taking it for 2 years and not mentioning it. So it's a good thing to mention any over-the-counter medications that you take when you go see your medical provider.
Yeah, great. Okay, I have 2 bonus questions we're going to get into the next 3 minutes, all right? And by the way, I have, people are liking your Concha. Concha Sitter is the best, and I think this one may have been, I can't read, oh no, it's still 3 exclamation points. Awesome lady, 1 exclamation point. Very informative with her patients and so caring as well, I agree. I agree with that. Blessed to have her, and you even got a heart emoji.
Oh, that's awesome. Thank
Yeah,
you.
yeah, thank you.
Have you ever gotten any heart emojis?
Nothing.
Aw.
I get nothing. All right, so for patients who have something called ulcerative colitis or Crohn's, there's some, in the last 10, 15 years, there's some new, what we call biologic agents out that really help people that have that disease and who should really be vigilant about seeing folks like you to get treated. Can you kind of talk us a little bit about that?
Sure. So as Dr. Bird mentioned, years ago, basically it was just oral medication. So these biologics are injections or there's infusions, which have made a great difference, because before we basically were just trying to treat the symptoms. Now the biologics are really trying to treat, but actually heal the mucosa of the affected portions of the digestive tract, because it can be small bowel disease or small bowel and large colon disease or just large intestine, but actually going in and treat and then help keep the patient in remission. I mean, obviously individuals will get periodic what's called flares, but the medications are, have vastly improved. The nice thing is, let's say if someone's also one, not to remember to take pills and maybe their disease has progressed, I guess it depends on how you look at it.
Yeah.
Because if some of the medications are you just give yourself an injection every 14 days, some of them are infusion, so eventually they'll get to an infusion every 8 weeks. It can be pretty simple. You just come into the hospital, get your infusion, off you go back to your routine, and you come back in 8 weeks later for your infusion.
Yeah.
So it really has made a big difference in people's lifestyle, because some people, based on their disease, were really confined to their home. They weren't able to participate in activities. Some, a lot of times, even missed a lot of work based on their symptoms. So it's made a big difference in their lives.
Yeah, so that's a good thing, and I think most folks who have that now are probably on some kind of regimen that involves those medicines. But yeah, that's one of the ways in medicine that we have made some progress, and in GI in particular, with that, and I would say Hep C have been really big deals,
Yeah, they have.
game changers, if you will. Final question: what's the favorite part of your job, Concha?
Seeing you.
Oh, that warms my heart. Oh, that's my heart over here.
No, my favorite part is actually working with shout out to all my team players that work in GI, both on the clinic side and at the hospital side. We have a great team of providers. I enjoy when patients come in that we can see the progression of what they came in for and the outcome and the impact that we've made on their lives.
Yeah. And you do. And so that is, I completely understand how that would be a lot of fun.
Mm-hmm.
Yeah.
It is.
Yeah, good. Concha, thanks.
Oh, you're welcome.
We'll have to have you back again sometime.
Definitely.
We kind of hit the tip of the
The
iceberg.
tip of the iceberg, exactly.
In terms of stuff.
I have to give a shout out to my son Philip. Hey, Philip.
Hey, Philip.
And my husband Randy. Hi, Randy.
Hey, Randy. All right, Concha, thanks a lot.
Thank you.
Appreciate it. Okay. I'll make sure. Oh, I want to just. Hey, Concha, 1 second here. Let's just make sure I don't need you again. What does it say here? Oh, okay. That one's on. Hey, there's someone actually saying something nice to me, and I got 4 hearts on emojis.
Oh, I'm sure somebody paid for those.
Thank you. Appreciate it. Okay, so let's talk COVID a few minutes. I'll try to keep it simple and short, but cases around here continue to happen. I think yesterday at the hospital, the testing that we did between Ready Care and everywhere else was about 5 positives. That's about typical, it seems like, right now. And then, of course, the health department, you pretty much about more than double in terms of, I shouldn't say double the number of cases, but I think last time, if I remember right, our cases were about half of what the total county cases were. So, yeah, it's still out there, still happening. Once again, it can happen on a fluke thing. You can get it if you're doing all the right stuff, but it's pretty unusual. Most of the folks who are wearing a mask and keeping away from folks and just being smart and not going to some big gathering and not being in a break room with a bunch of other people with your masks off and all those kind of things. By and large, those folks are doing really well. So keep doing that. I really encourage you to. I'm sure all of those of you who are watching this are keeping up to date on this stuff, but obviously right now, one of the hot spots are colleges. I got a thing. My youngest he's doing a co-op this semester, but he goes to UW-Madison, and I just saw a thing last night that they are asking the students in the dorms to basically quarantine for the next 2 weeks, and all classes are going online for 2 weeks. And that's all the off-campus parties, social stuff that's happening that's really causing the problem. So I saw something where one of our Illinois State was getting a little bit of heat because rather than keeping kids who test positive at the college, they're sending them home. Well, I get it and I don't get it. if you're gonna so anyhow, colleges are taking some heat right now in terms of you want to have school, you want to get your tuition, but you got to have some contingency plan for when kids get sick and not just send them on their way home and be with their other people who don't have it and being in that home and then causing more problems. So anticipated that being a problem. It is. Schools continues to be a work in progress. We'll see how long that all continues, and hopefully it does. But you know, the reality is that's it's better, I think, because you're at least for the students in the school who are doing this, it's a better deal than folks who are out of school, and that just like here, it's not by and large seeing patients. It's outside of that where we have issues. So I encourage folks just to be smart about all that stuff, and I think you'll be able to work your way through this pretty well. Once again, we're glad to do this. Next week we have, I know, this is going to be, I think you're going to really enjoy this one. At least I get into this stuff. We actually have someone in their full-time job here at CGH. It's Matt Reed is the fellow's name. And Matt does security, internet security for us. And so he's going to come next week and talk to all of us about what we do here at the hospital to protect our data and your data. And then if we have some extra time, we're going to talk about some tips for you to protect your data at home and on your home computers and those kind of things. So yeah, let folks know about it. I think it's been really interesting to have Matt on with us next week. So until then, thanks for listening, and we'll talk next week. Bye.